Okay, so today we are going to discuss malignant hyperthermia, critical care station. A 19-year-old girl is about to undergo appendectomy who presented with acute appendicitis. In the OR, the patient was given inhalation anesthetic halotene and succinylcholine as muscle relaxant. So, not in the OR. Yes, in the OR, when we were performing appendectomy, so we give GA, general anesthesia. So what's going on? So there is two, an inhalation anesthetic, which is halotene, and the succinylcholine is used as a muscle relaxant. Before making the incision, patient developed vigorous rigor and spasm. Body temperature was increased to 41.4 degrees centigrade. Dekho, remember when you have given the muscle relaxant and the other like anesthetic agent, so normally the patient gets relaxed, and you can, like, even before like intubation, then we give muscle relaxant and the patient gets relaxed, and then it's so easy then to put the intubation to laryngoscope. But when there is a malignant hyperthermia, the patient, instead of getting relaxed, it will get stiff. So this is the very early sign of malignant hyperthermia. So there will be vigorous rigor and spasm. Body temperature will rise up, and like here 41 degrees centigrade. So what is your proper diagnosis? Your proper diagnosis should be malignant hyperthermia. What is malignant hyperthermia? Malignant hyperthermia is an autosomal dominant severe life-threatening drug condition and classically present as a hypermetabolic response to halogenated anesthetic gases and or the depolarizing muscle relaxant succinylcholine. Both can cause malignant hyperthermia. What is the mechanism of pathophysiology of the malignant hyperthermia? So, conditions seen following administration of anesthetic agent caused by depolarizing muscle relaxant succinylcholine, succinylmethonium, and dicamethonium. Volatile anesthetic like halotene is in the above. In the above, there are two. Antipsychotics like valproic acid can also cause malignant hyperthermia, caused by excessive release of calcium from the sarcoplasmic reticulum of the skeletal muscle, cause the muscle fiber to contract. Unregulated release of calcium. This generates excessive heat and muscle rigidity associated with defects in a gene on long arm of chromosome 19, mutation of the ryanodine receptors type 1. Ryanodine receptor type 1 mutation. Okay, so what will happen? This is the diagrammatic representation that you give the anesthetic and it will trigger the ryanodine receptor excretion. Okay, here. So there will be a lot of calcium release and there will be unregulated muscle contraction. Okay, so as you know, when we are like, it's just like unregulated exercise, excessive exercise, a vigorous exercise. So this will also produce heat and there will be rigidity. Okay, skeletal muscle breakdown, which will release rhabdomyolysis. It will release myoglobinuria as well as potassium. Potassium will go up. So there is a high chance of arrhythmias, plus there is a high chance of ATN, acute tuberous necrosis, due to myoglobin in the blood. Okay, so these what are the symptoms in malignant hyperthermia? Muscle rigidity, masseter spasm, masseter muscle in the mouth is early sign. Masseter spasm is the early sign. So the anesthetist will be unable to intubate the patient. So just avoid or abandon the surgery. Fever, tachycardia, tachypnea, hypertension, abnormal heart rhythms, and mixed acidosis, rhabdomyolysis. Okay, what are the lab findings? Increase muscle type creatine C kinase, creatine kinase MB. This will increase, go up. Potassium will go up. Hyperkalemia and metabolic acidity will increase. Anion gap. Hypocalcemia, because it will go all inside the cell. Okay, so there will be hyperphosphatemia. Yes, hyperphosphatemia and hyperkalemia. These will be the electrolyte disturbance. Increased lactate dehydrogenase LDH and creatinine kinase MB. So myoglobinuria suggested by positive dipstick to blood in the absence of hemoglobinuria. Red cells are microscopy. So there will be muscle breakdown, rhabdomyolysis, and insulin and blood dipstick. There will be positive. Susceptibility testing, muscle biopsy, and genetic testing. Okay, take a muscle piece and do genetic testing. You will get the mutation. Mutation for what? Mutation for ryanodine receptors. Ryanodine receptors. What should anesthetist do? What would be your management? So, management is always according to CRISP, CRISP protocol. Stop the triggering agent, abandon the operation, call for help, take control of ABC, airway, breathing, and cardiovascular as part of a CRISP protocol. Administer dantrolene. This is the antidote. 2.5 milligram per kg until the erection subsides, up to maximum dose of 10 milligram per kg. Continue dantrolene at 1 milligram per kg every 4 hourly for 24 to 48 hours. Okay, increase ventilation to lower end tidal CO2. Cooling measures, cooled IV fluid, ice packs to expose surface area to decrease the temperature. This dantrolene to antagonize the ryanodine receptors, so it won't release the calcium into the skeletal muscles. Laboratory tests for ABG, so these are supportive. ABG electrolyte, give him calcium gluconate and do measure for degrees of potassium, because potassium can cause arrhythmias, fatal arrhythmias. Okay, urine for myoglobin, give a hydrate the patient. Coagulation profile. Ensure urine output of 2 mg per kg per hour. Mannitol 3 gram is included in each vial of dantrolene. In each vial of dantrolene, give also 3 gram of mannitol. Why? To increase output to prevent the AKI or ETN. So this was all about the management of this malignant hyperthermia. So we will go further. How does dantrolene work at malignant hyperthermia? Dantrolene works by inhibiting calcium-induced calcium release from the sarcoplasmic reticulum. Its mechanism of action is through antagonizing the ryanodine receptor. Simple. Ryanodine, it blocks the ryanodine receptor, so there will be no calcium going inside, which lessens the excitation contraction coupling of muscle cells. Dantrolene is currently the only specific medication used for treating malignant hyperthermia. Can surgeon continue with surgery? No. Diagnosis of trismus after giving succinylcholine with the induction raises the question of whether the surgical procedure should be cancelled. A clinical episode will follow the trismus 20% of the time. When the anesthesia provider first suspects that an malignant hyperthermia reaction may be occurring, the surgeon should be notified promptly and a decision should be made about whether the procedure is to be continued or cancelled. If the procedure is cancelled, the patient should be observed in the hospital for 24 hours for sign of malignant hyperthermia. This means that first, when you given the anesthesia is given the succinylcholine, he will notice rigidity in trismus instead of relaxation, and he will be unable to pass the intubation endotracheal tube. So he should notify to the surgeon. What are the complications of malignant hyperthermia? Renal failure due to myoglobinuria. Okay, so renal failure due to myoglobinuria, and what else? Electrolyte imbalance, hyperkalemia, cardiac failure, malignant arrhythmias, irreversible brain damage can occur. Okay, if the procedure is to be performed, the following considerations should be kept in mind. in planning anesthesia for an malignant hyperthermia susceptible patient. So avoid triggering agents. So don't give succinylcholine or halothane. We have propofol nowadays. Major inhalation agent and succinylcholine. Use non-triggering general, regional, spinal, epidural, or local anesthesia or monitor anesthesia care. Watch for signs of malignant hyperthermia. Use a clean anesthesia machine. Remove vaporizers or tape them in the off position. Change soda lime and barium hydroxide lime. Replace the circuits. Replace the fresh case tubing if possible. And run oxygen through the machine at 10 liters per minute for 20 minutes. 10 minutes if the fresh gas tubing was replaced. The procedure can be done on an outpatient basis. If all goes well, the patient can safely be dismissed after 2 to 3 hours. Discharge. Okay, so they're saying that if it's a day case procedure, he can be discharged after 2 to 3 hours. So basically what they say that if you have a patient which is a history of malignant hyperthermia and he's presented for some procedure, so you have to take all the precaution, change tubings, so that even like a little amount of anesthetic which can cause malignant hyperthermia, this should be avoided. For example, the triggers like succinylcholine, halothane, these all should be avoided. Use alternatives. And also keep the team ready for the management as well. How it can be avoided? There is no treatment to reverse the genetic defect, so you can't do anything about the genetic defect that causes malignant hyperthermia. Pay close attention to temperature and other basic measurements during procedure with anesthesia. Responding early to changes in these measurements can help prevent malignant hyperthermia emergencies. Certain precautions should be taken before anesthesia of patients known to be susceptible to malignant hyperthermia. What are these precautions? The prohibition of use of triggering agents, monitoring of central body core temperature and expired or exhale CO2, immediate availability of dantrolene, this should be kept ready, and a careful cleansing of the anesthesia machine of vapors of halogenated agents is recommended. Okay, so this was the station about malignant hyperthermia.